Everybody can hear me, right? Okay. Good morning. I hate standing up there, and actually I want to point to some of the slides. So, I forgot how to, then I have to change this. Great. Okay, great. So what I'm going to do is actually, originally it's going to be a workshop, but now instead it's going to be a lecture, which is also fine, can be done either way. Now, what I'm going to focus on is the screening and prevention of cervical cancer. So basically what I was trying to go through is really not that new anymore, but it's still the most updated screening and management guideline, which is put out back in 2012 by the ASC-CP, American Society of Colposcopy and Cervical Pathology, together with the American Cancer Society, etc. I mean, they had a meeting back in 2012 in Bethesda, and then published the guideline. And then also later on in April 2014, Roche actually put out this new product called Cobas, which is HPV testing, which they tried to market it as a primary screening for cervical cancer. It was HPV alone, which actually was FDA approved. But that created quite some issue about how do you come about using that, which I'm gonna, and so the American Cancer Society and ASC-CP together put out another interim guideline back in 2015 about this. This, again, is just an interim guideline, still nothing definitive. At this point, everything still stick to the 2012 guideline. And the figure is always almost 5 years now, but I come across a lot of consultations that a lot of practitioners still not quite so familiar with exactly what the guideline is and how to manage. So we're going to briefly review this and also use some practical cases to kind of run some exercise, and it can be interactive. If you have any questions, interrupt me at any point and we can talk about it. This is a brief introduction slide. As you can see, cervical cancer incidence rate has been decreasing. This is from 1999 to 2013. The biggest drop really is among the Hispanic and African American Black populations. Same thing with the mortality rate, and also you can see Hispanic and Black populations actually is dropping the most. But overall trend for all races, for all racial and ethnic groups, it's all cervical cancer is actually in the United States is really coming down significantly. The CDC data from 2013, this is the last complete data they have. About 12,000 women diagnosed and about 4,200 died in the United States. And the estimate from American Cancer Society is about 12,800 and about, again, 4,200 will die. More than 90% of these are HPV related. If you really look at the attribution of the HPV to these cancer and high-grade dysplasia, you can see this is cancer and this is CIN3. This is what we focus on. 16 and 18 are really the biggest offenders here. I mean, they contribute the most. There are other 10 other types of carcinogenic HPV that's well known already, but they're only just a little bit. I mean, the big thing is still 16, 18. That's why the whole screening is all focused on that. This is just an introductory slide for human papillomavirus. As Dr. Ablafi already pointed out earlier, the double-stranded DNA virus. This is a typical representative of HPV 16. There are late transcription genes and early genes, and then E6, E7 is really the origin of the carcinogenesis. They disrupt and cell growth. E6. So this virus actually, once they infected, they will the viral DNA will get into the nucleus, and the E6 will bind to P53 and E7 bind to retinoblastoma. And so it ended up causing inhibition of apoptosis and also promoting the cell cycle. So ended up it will become a HPV-induced cellular transformation, which I'm not gonna. That's not the focus of this talk. And so high-risk carcinogenic really is these 12, and these 12 are the one that Cobas actually covers. 16, 18 is the two big ones, and then there are the 10 of them. Okay, and there are obviously some other ones. And low risk, I don't think we even screen for that nowadays because it really doesn't cause cancer. Cause other problems, but doesn't really cause cancer. You look at the prevalence of HPV infection, who actually gets infected, really started in early, like teenagers, when they first become sexually active, peaks in the college age, okay, and then gradually coming down. So that's why, in general, the best time to immunize them with HPV vaccine really starting from age 9. Okay, if you can finish immunizing them between age 14, that's great. Okay, but the guideline, obviously, FDA approval, obviously, you can extend it to age 26, but really, you're somewhere here. You probably, for the most part, you already kind of got exposed. And once you get exposed, really, the vaccine really doesn't mean anything anymore. So this is actually the cumulative data from 2003 to 2005, and look at the prevalence of high-risk HPV and the incidence of cervical cancer. As you can see, again, dividing the age group, the incidence of HPV again peaks in the young age, okay, when they start becoming sexually active, and then as they go older, the HPV incidence just drop. Whereas the cervical cancer incidence, as you go older, cervical cancer goes up. So this also point out one phenomenon that yes, carcinogenic HPV does cause cancer, but doesn't cause cancer right away. I mean, this is something take decades of brewing, and then eventually, when you get to older age, and that's when the cervical cancer then you suffer the consequences, basically. And this is how the natural history of cervical cancer and the HPV infection. Basically, once you get infected with HPV, either you got spontaneous regression, your body's immune system just take care of it, but doesn't take care of it right away. So, there are practitioners try to keep retesting them in 4 months, 6 months. That's kind of a bit premature. In general, maybe you can wait up to a year to test them because it doesn't go away right away, but eventually you can, or they can go to CIN1. And even CIN1, about 70-75% of them will spontaneously regress without any medical intervention. And it also takes quite a bit, 6 to 24 months. They can obviously go straight to high-grade dysplasia or go through persistent CIN1 and go to CIN2 and 3, and then eventually develop invasive cancer. The key really is from CIN2 to 3 to invasive cancer, it takes about average 10 to 13 years. Okay, it's from this point. It's not from here to 10 to 13 years. So really from here to here, it really just already take almost a decade already, and then take another decade and a half to develop. So that's why in the previous slides it showed that age distribution thing. So let's get into the 2012 guideline, and this was published in the Journal of Lower Genital Tract Disease, which is the official publication of American Society of Colposcopy and Cervical Pathology. And these information is all on their websites. You can very easily find it. The new endpoint really is not cervical cancer. As we keep saying, is screening for cervical cancer. The endpoint is not cervical cancer. Endpoint really is a CIN3. That's when we reach the endpoint and we will treat and stop it at that point. Okay, instead of wait until the cervical cancer is already detected and then you try to stop it at that point. That's one step too late. So endpoint is CIN3, and this is the change, really the major point of the new guidelines, which younger than age 21, there's really no screening. Okay, from 21 to 29, you can do cytology alone every 3 years. You only do HPV reflex on the ASC-US pap smear, but otherwise, you don't really use HPV, you don't really test them for HPV, which we'll get into that in a little bit. This is the age that we really screen, according to the nature history of HPV infection. So this is the age group that we're focusing on. So you can either do just cytology every 3 years or co-test every 5 years. And this is the period of time HPV is routinely being tested, and actually the genotyping of 16, 18 is highly recommended at that point. All right. Now, when you're older than 65, they're recommended stop screening. There's a little bit issue about this, which we're gonna, talk a little bit more about. But the bottom line, the key point really is you really have to stick to the rule that there's no history of CIN2 for the past 20 years, and the patient has to have adequate screening. Well, this automatically ruled out a lot of our patients. So even though it looks like we try to stop people getting screened over age 65, but really it's only very limited. I mean, it's a very focused population that's can get out of the screening. Like in this community, a lot of patients unfortunately still need to be screened. Yeah. Well, make a long story short, make a long answer short, those patients need to be screened because they do not fit this. I will get into this in a little bit. There are a couple of slides later. It will specifically talk about the patients with incomplete history, and those need to be screened. So unless you 100% meet the criteria, otherwise they should be screened, period. Okay, we'll talk about that in a bit. No. This is part of the co-test. Yeah, this is part of the co-test, and I will get into the co-bands test a little bit later on. But this is part of the co-test. And after hysterectomy, similarly, you apply the similar guidelines, and regardless your HPV vaccination status, the screening is age specific. Okay, so there's really no change. Now, so let's just start from the youngest of the patient populations. I mean, under age 21, the incidence of cervical cancer in this group is 0.2%. So of the entire United States population, only 24 women diagnosed each year. Okay, so this age group of patients actually recommendation no screening, and it's for the most part it's not cost effective at all for picking up 24 patients out of the entire United States population. Now, so from 21 to 29, cytology alone every 3 years, that's a recommendation. Why go so far apart? If you really look at the lifetime risk of developing cancer, cervical cancer specifically, okay, if you do annual screening, we can pick up 3 per 1,000. If you do every 3 year screening, we pick up 5 to 8 per 1,000. So in other words, you will pick up additional 2 to 5 per 1,000 patients, okay? And the risk of dying from cancer, this is just diagnosed, dying from cancer is 3 per 100,000 in the annual screening group, but 5 per 100,000 every 3 years. So you pick up 2 per 100,000 patients among this age group. And this is the reason why, remember, this is a screening, okay? We're not trying to diagnose every woman with cervical cancer in the United States, but for screening, there's screening strategy. I mean, it has to be cost effective. That's one of the criteria. So this is another reason why they feel comfortable extending it from annual, once a year, pap smear to every 3 year screening. Now, coming for colposcopy is A, time consuming, and B, it's nerve wracking, and then C, a lot of times, the patient has to take off from work, or, there are a lot of associated issues, not to mention, it's not the most comfortable exam, and on top of that, if you have to do biopsies. So in general, it should be done in the indicated fashion. Now, so if we look at really among this age group, if we screen them every 3 years with pap smear, okay, they actually estimated every 1,000 women they will generate from the abnormal pap smear, they will generate about 2,000 copos. Now, if you're screening every 3 years, every 1,000 women will generate about 760 copos. So in another word, there were, I'm sorry. Now, so if we change the screening strategy, I mean, there will be about a little over 1,200 less colposcopy done in the, per year, okay? So then the next age group, 30 to 64, I mean, the recommendation is pap smear alone every 3 years or co-test every 5 years. Now, how about over age 65? you need to have, this is the key, adequate negative prior screening. Okay, you need to have 3 consecutive negative Pap. If you're doing Pap alone, you got to have 3 negative ones every 3 years. You do co-test because every 5 years you need to have 2. Basically, within the last 10 years, you need to have the screening and sorry, let me just turn it off. Sorry about that, let me just turn it off. So in another word, within 10-year period of time, if you're doing just Pap alone, you should have at least 3, right? Because every 3 years. If you're doing co-test, you should at least have 2. So in other words, in the past 10 years, you got to have all these negative, and with the most recent exam in the past 5 years. And on top of that, no history of CIN2 in the past 20 years. So this itself, if you really want to exit the screening, you really have to go by this rule and not missing any one of this. I mean, even if the patient has this, but they have CIN2 like 15 years ago, they had a leap or was treated, they don't meet the criteria. They need to continue to be screened, okay? Now, so a lot of times actually why providers don't stop screening. I don't know the patient's Pap history, that's one of those reasons. And I don't believe in stopping, okay? Put away the financial issues. Well, let me make one thing very clear. The patients should have annual GYN examination, period. This is examination when you get the Pap smear, okay? So the patients should still see the gynecologist every year for breast exam and, to make sure their colonoscopy is up to date and have a normal physical examination. And Pap smear is only part of it, all right? So even though Pap smear is done every 3 to 5 years, the patient should still have exam every year, okay? So that's different. The other commonly reason was reported, my patient is high risk or my patient has a new partner, okay? There are some studies actually looking into this new partner issues, and they really, when you reach the exit age, when you have a new partner over age 65, actually really the incidence of new cervical cancer really is not statistically significant. It doesn't really contribute additional cervical cancer incidence. Now, my partner is high risk. Now, what is high risk patients? I mean, it's not like where you practice. I mean, we'll say, okay, Brooklyn patients are high risk patients, or Bronx patients are high risk patients. It's really not that. This is not a geographical, criteria. What is a high risk patient? The patient ever had a history of CIN2 or 3 or invasive cancer. You can be anywhere in the United States. If you meet this, you're high risk, okay? Or you have a history of DES exposure. DES was actually used between 1940 to 1971, okay? And so really that generation is so far away, but if you keep up with the medical literature, they're actually started looking to, well, the second generation actually is getting the, has, cancer like vaginal adenosis and the clear cell carcinoma. Now even look at third generation, their reported third generation DES descendant has infertility issues. So DES actually has a long-lasting effect, but so these are, whether there's any increase in cancer incidence, we don't know yet, but National Cancer Institute is closely following among these group of patients. So, but it's kind of, a bit away from now. Immunosuppressed or compromised HIV patients, dialysis patients, these are the patients, or people are on chronic steroids. So these are the patients that actually you really need to keep an eye on. So this is actually a very busy slide, but I'm going to just use the ACOG recommendation because these 3 groups, United States Preventive Service Task Force, and ASCCP and ACOG, they all basically, these 3 are the same thing, all right? And this is the old guideline from ACOG. So I'm going to just make a brief comparison. Under age 21, there's really no change. 21 to 29, it used to be cytology every 2, now it's every 3, okay? Slightly longer. 30 to 65, they used to recommend co-test every 3 years. Now you can do Pap alone every 3 or co-test every 5. All right. Now, the exit screening, okay, I already briefly mentioned about the exit criteria right now, and I'm not going to elaborate on this. After hysterectomy and HPV vaccination, I already briefly mentioned about it. All right. So, where do the screening fail? I mean, in the United States, we still see people. So theoretically, in ideal situation, if we stick to the screening guideline, we should not be seeing cervical cancer at all. So where the screening fail? 50% of cancer diagnosed in the United States women never got screened. And then another 10% of them actually are who has not been screened for the past 5 years. Okay, so in other words, people don't go for the screening. So, and who are these people who are actually not getting screened? Well, according to all these data, it's usually minority patients, okay, lower socioeconomical status, including education levels. Okay, they're not educated to do that. Foreign-born moved to the United States in the past, within the last 10 years, who actually never have a screening in their country, which we actually saw quite a bit in this community, or just simply no usual source of health care. Okay, so then so I'm going to elaborate a little bit more on the management guidelines for the when you have these screening abnormal Pap results and co-test screening guidelines, and I'm going to use some practical cases to go through it to make you understand. Now the focus really is, the update is, there are a couple of key things. CIN1 on ECCs, okay? And co-testing and genotyping, this is another focus. Changing adolescence criteria to age less than 25. Unsatisfactory Pap, what we do with it, missing endocervical components, and when to return for routine screening. I'm gonna give you another very busy slide, but after this, we can, once you understand this, then you can, when we go through the algorithm, it'll be very easy for you. Now, so just bear with me. We're going to go through this. I don't like busy slides, but I'm going to go through this in a little bit more detail. So if the Pap smear reported negative but lack of endocervical components, you can manage without early repeat. Okay, you can manage without early repeat. Now, this is different from unsatisfactory. Okay, you can have a Pap smear but show no endocervical component. That's different from unsatisfactory Pap smear. Unsatisfactory smear just too few cells that you just cannot see it. Okay, so so that's a little bit different. Now, CIN1 on ECC, it should be managed as CIN1, not to take the patient to OR and do a co-knife cone on them. All right, positive ECC is only for the indication for co-knife cone is only for positive ECC for high-grade dysplasia, not for positive ECC or CIN1. This is managed as CIN1, okay? Now, cytology reported satisfactory, okay, requires a repeat, okay, even if your HPV is negative. So again, this is the same thing as I mentioned earlier. You don't have enough cells to evaluate the cytology. Now, genotyping triage, HPV positive women, the 16 or 18 to early colposcopy. So if there are 16, 18, as you will see a little bit later, if you're the bottom line is if you have 16, 18 positive, you need colposcopy, all right? The other 10 types, then it really depends on the Pap smear, as you will see a little bit later. For ASC-US cytology, you don't really need to do colposcopy immediately. But then the recommendation is actually repeat a cytology in 12 months, not 6, not 12. And then if negative, then cytology every 3 years. We'll get into this in a little bit as you go through a couple of times. You have to. So the HPV negative and ASC-US PET results should be followed with co-testing at 3 years and rather than 5 years. Okay, because this is not entirely considered as negative. Again, this result is insufficient to allow exit at age 65 because again, that's still abnormal. All right. Now the pathway to long-term follow-up of untreated and treated and untreated CIN2 is more clearly defined by incorporating a co-testing. So basically, these patients need to be continued to be tested, and actually the preferred way to test them is really a co-test, so you will know their HPV status. all right? And so I'm gonna go through some practical cases that you can see, take you through the algorithm, so it'll be much more clear for you, all right? So the first patient, 21-year-old, come for the first pap smear, first time seeing in your office, okay? So, she's 21, so we did a cytology only, come back negative. You have her come back in 3 years. She came back in 2, pregnant. Now, so do you need to do pap on the prenatal? You don't have to, okay? So no pap needs to be done. Well, maybe I should change the word. It's not should. It doesn't really need to be done. Now, so she come back age 24, got a second pap smear. She's still 24 years old, right? So you only have to do pap smear, no HPV testing. So come back, ask us. So how we deal with this? So women 21 to 24 ask us or low grade, they prefer, as I highlighted in red, is repeat cytology in 12 months. So repeat another one. If it's negative, then you repeat it another one in 12 months. So you got these 2 negative, then you can exit to go back to routine screening. Okay, so in another word, they start using once a year cytology, and this is all just cytology. But if any of this is negative, is abnormal, this is abnormal or this is abnormal, then she got a Colpo. Then you got 2 pap that's abnormal. Even if it's ascus, then you need a Colpo, all right? I mean, you can certainly do a reflex HPV testing, but it's only for ascus, not for low grade. Okay, and if it's negative, routine screening. Positive, you still ended up, prefer to still pap them in 1 year. So this group, that's why it's really not strongly recommended to do HPV testing, because this is a group of patients you're gonna repap them anyway in 1 year. So she got repapped in 1 year. Now she's 25. It's still ascus and reflex HPV positive. Well, from the previous slides, we know she's gonna get a colposcopy, right? So if you repeat pap, if it's negative, you go back to routine screening. But in her case, it's abnormal, so she got a colpo. Or you can do HPV testing, which is preferred, okay? And I circle in red. If it's negative, then you can do, so if this is negative, so you have ascus, pap, and negative HPV, then you can do co-test in 3 years. You will see this happening a lot. The ASC-CPE is trying to triage this patient by repeating a pap in 1 year, and then repeat another pap in 1 year, and they're kind of relatively assured that they will do a co-test in 3 years instead of 5. They will do in 3 years to kind of do like a follow-up reassurance, and then if that co-test 3 years later is negative, then they will go back to the routine pap 3 years or co-test in 5. You will see this strategy being used a lot. So then, as I mentioned earlier, because she's HPV positive, ascus, pap, so she's getting a colposcopy. The colposcopy showed adequate colposcopy, ECC was done, which is fine, multiple biopsy, CIN1 and ECC CIN1, right? As we briefly mentioned earlier, this is the guideline. So if you have CIN1 and the pap is no higher than CIN1, ascus or low grade, then these you can follow up without treatment. You don't need to jump on it. Okay, and those, so you do co-test in 1 year, is negative, then again you see this, they do it in 3 years, okay, usually it's co-test and then go back to screening. Now if any of these is negative, is abnormal, then you get a colpo, and then you get a colposcopy, okay? So not upfront, and you do another co-test, and if anything positive, then they get a colpo. Now, so then she got a colpo she got a co-test in 1 year, even though she's under age 30, right? Because this is for different purposes. This is not for screening anymore. Now we're monitoring her, okay? So she come back age 26, co-test, both negative, all right? And so again, she was here, and then she got a co-test negative, okay? So then, technically speaking, you can monitor a co-test in 3 years. So she come back age 29, cytology alone was performed, which is fine, no evidence of malignancy, and the transformation zone was missing. So no endocervical components. So then, what happens when you have missing a transformation zone? So because she falls into age 21 to 29, so then you would do routine screening, right? But if you're older, then you will look into, because it's going to be a co-test, so you will see the HPV status. HPV is negative, then you can safely screen them without having to, even though it's missing the transformation zone or endocervical cells, okay? Now, if HPV is unknown, okay, then the preferred is doing the HPV testing, or you can choose to repeat in 3 years. This is also acceptable, okay? Now, in general, it's really not recommended to do HPV testing in a woman who's 21 to 29 years old. Okay, now, so she come back at age 30. She has her second child, and again, she's pregnant with a second child, and again, no PEP was done, all right? Now, and 2 years later, age 30, to come back for her regular screening. So at this point, everything is all, you know, this is her routine follow-up PEP now. So you can do cytology every 3 years or co-test every 5. So come back, so she did this. Come back cytology negative and HPV positive. Okay, so we're kind of growing up with her. Now she's 32, a negative PEP, positive HPV. So what do we do? So now she's over 30. Okay, it's negative and HPV positive. You can do either. You can do a co-test in 1 year again. If they're still negative, then you do co-test in 3 years, not 5. Okay, you see this strategy as I keep mentioning. Now, if any of these is abnormal, she get a Colpo. Or, since we're doing the HPV testing, then you can do the genotyping. If it's 16, 18 specifically, then you do Colpo. If it's anything else, okay, the other 10 other carcinogenic HPV, you can do repeat co-testing in 1 year. Now, these are the guidelines, okay? I mean, a lot of times you will see physicians actually choose to go ahead and do Colpo. There's probably nothing wrong with it, but it's just the guideline says, you know, this is actually, you know, it's acceptable to manage the patient this way. All right. Now, so she elected to have a genotyping and both negative. So we follow the guideline. We do a co-test in 1 year. She come by age 33, had a co-test, both negative, so repeat co-test 3 years, right? This is a follow-up. This is not a screening. So co-test in 3 years. So she had abnormal, looking back, she had abnormal pap smear on and off for about 9 years. Only 1 colposcopy, okay? And she probably cleared HPV more than once, and she was probably infected with a non-16, 18 HPV. She does have slightly increased risk over general population developing CIN3. So it's not unreasonable to screen every 3 years should you choose that. But if you want to do every 5 years, that's also okay, all right? So this is for the first patient. So everything is good, right? Okay. Now, I'm sorry, I missed that. I'm not sure I missed, at which point? Here?
Right, okay, yes. So HPV 16, 18.
But she was non-16, 18. Well, I'm sorry. She was positive, right? So then you can either do this or you can choose to do genotyping. So then we did a genotyping and it's negative. Okay? So if the genotyping is negative, it's reasonable to do a co-test in 1 year. You don't have to jump to Colpo. The whole thing is the whole essence is when the patient really need a colposcopy. That's the bottom line question. And if she, in her case, she had 16, 18 positive, either of them positive, or even worse, both of them positive, then you need to do Colpo.
My question is, after she does the repeat co-testing in a year and it comes back negative, why don't you go back to every 5 years?
That's why I said it's You can, but the reason is that's why I put a star here. That's why I was trying to emphasize. I mean, they use this as a follow-up because we have been following the patient with co-test in 1 year. As you can see the strategy, they have been using co-test 1 year, and then it's all negative, both negative, then they will do co-test in another year. Both are negative, then they will do co-test in 3 instead of jump straight to back to 5, because they do have slightly increased risk of CIN3. They do. Okay, so it's not unreasonable to do it. It's not unreasonable to do it in 3 years. Should you choose that? That's at physician's discretion. All right. I'm sorry? At this point? Yes. At this point, if co-tests are both negative, you go back to 5. Then you fall back to the screening algorithm. You go back to the track. Yes. But there's also nothing wrong of doing it 3 years, should you choose to do that as a doctor. Okay? It's a guideline, it's not law. Now, second patient, 34-year-old new patient to your practice, no pap history, no idea whatever she had done, she last pap was, or she ever had one. So you do a co-test, right, age appropriate. So it's a low grade and HPV positive. So if it's a low grade already, why do we need HPV testing? I mean, shouldn't she go straight to Colpo, right? No, if you look at the guideline here, low grade, okay? And if you have low grade with, this is the only thing they're focusing on. The low grade with negative HPV, the preferred is repeat co-testing instead of jump straight. And this is the only time. But otherwise, if no HPV testing or positive, they all go for Colpo. But that doesn't mean, again, you cannot send them for Colpo. You can, okay? So here, she's low grade and HPV positive, so she's over here. Then you know she's going for Colpo already, all right? Now, if then with a CIN2 or 3, then you know you manage accordingly. But HPV is only useful, so why doing HPV in her since she's already low grade? Because there is a situation, if it's HPV negative, you don't really have to do Colpo on her. You can choose to do co-test. If they're negative, then again, you fall back to the, you know, to the follow-up algorithm, okay? Now, so we did a Colpo and ECC according to the guideline, multiple biopsy, CIN3 on the ECC and CIN2 and 3 on the biopsy. All right, so this is clear cut. What are we going to do about this? She needs a cone, right? So if adequate colposcopy, you need to have either excision or ablation. I think nowadays everybody will do excision, right? Because the benefit is you have a pathology specimen, tell you whether, you know, do you have invasive cancer or not? Is it truly CIN2 and 3? And whether, you know, your margin status, did you clear the lesion? Now, if you have inadequate colposcopy, recurrent CIN203, or positive ECC, you need to do a lead. So either way, adequate, inadequate, in this case, you need to do a lead or cone. So after you do the cone biopsy, how do we follow up? I've seen a lot of practitioners actually start doing pap smear 3 months later or 4 months later. That's a bit too quick. So the recommendation is actually do a co-test at 1 year and 2 years. If both are negative, then again, you see this pattern now in 3 years. And it's negative, then you can go back to 5 years, okay? Now, however, if at any point, any of this is normal, you go back to the colposcopy part, all right? So she had a co-knife cone. Pathology is because positive ECC for CIN3, there's a clear-cut indication. So showed invasive cancer. Well, did we fail the patient or is it really her issues? No, because she never got adequate screening appropriately, right? Okay, now, so the second patient is good, right? Good, all right. Now, the third patient, 25 years old, first pregnancy at 16 weeks, showed up in your office. Never been to a gynecologist before, and then you did a pap smear, low grade. All right, 25, so you go by the rules, you don't do HPV testing, so we don't know the HPV status, but you did a PEP, low grade. So then here, this is a pregnant woman with a low grade. The preferred is colposcopy, okay? And the purpose of colpo is to rule out high grade or invasive cancer. That's the only purpose, all right? So you look at it, and you want to make sure there's nothing that, especially invasive cancer, you want to make sure there's nothing suspicious. But otherwise, the patient choose not to, you can defer the colpo until 6 weeks postpartum, okay? But, so this patient choose to defer until 6 weeks postpartum. When she come back 6 weeks later, it's not repeating a PEP. This woman owe you a colpo. You still need to use colposcope to take a look, all right? So not PEPing them, all right? So then we did a colpo. It's adequate colposcopy. You didn't do ECC because it's adequate. You can see the entire lesion, totally acceptable. Multiple biopsy and cervical biopsy, CIN1. All right, so we go back to this now. CIN1, previous PEP is also low grade. Then you fall back to this co-testing algorithm now, okay? Which now she's no longer pregnant, so you fall back to the algorithm. So we did a co-test in 1 year, and even though she's under 30, remember, because now you're monitoring her disease, you're not screening her now. So it's co-test. Now, so she's 26 years old, we did a co-test. Atypical squamous cell favor high grade, HPV positive. This thing is different from ascus. This thing should be viewed the simplest way. Don't make it too confused. Simplest way is, look, when you see this is high grade. So look at it as a HGSIL, okay? That's the easiest way to manage. Because with atypical squamous cell cannot rule out high grade, it's mandatory colposcopy, okay? And then if you either see it, you don't see it, then you manage accordingly. So this patient is automatic, regardless of the HPV status. Now, so we did a colpo, it's adequate, okay, and ECC is acceptable, and multiple biopsy was done, cervical biopsy CIN1, ECC negative. So what's the issue now? She had a PEP that's ASC-H. So there's a 2-grade discrepancy now, right? It's a 2-level discrepancy. So what do we do? What do we do with the 2-grade discrepancy? One of the indications for cone biopsy or LEAP is 2-grade discrepancy, right? Between the colposcopy diagnosis and also the PEP. So you can do a cone, or if you really have some time, you can pull out the slide and track down the slide, call up LabCorp or Quest and track the slide, spend the next 3 months and try to review it with your pathologist. That's reasonable. You can review it and make a recommendation, or you can do a co-test in 12 and 24 months, okay? Same strategy, if both negative, then you go back to age-specific screening in 3 years, and or if anything is abnormal, you do a colpo, okay? And if any of these is high grade at either visit, then you get a LEAP. So this is for 2-grade discrepancy, okay? Slightly different from before. Now, so we did a co-test in 1 year and 2 years, right? So we actually followed down this route. We did it 1 year and 2 years, so age 27, both negative, 28, negative. So go back to screening every 3 years. So come back 3 years later, did a co-test, unsatisfactory cytology, HPV negative. Now, this is unsatisfactory, as I mentioned earlier. It's different from you had a PEP, you know, it's negative, but lack of endocervical component. That's a totally different thing. Unsatisfactory, you need to basically, regardless HPV status, how old you are, repeat a PEP in 2 to 4 months. Okay, you got to repeat it. And why? Because if you're using conventional cytology, then usually it's because it's too bloody or inflammation or poor fixation, or you waited for too long, all kinds of these artifacts that the cytopathologist cannot read the slides. You use a liquid base simply because you did not get enough squamous cell. I mean, we saw this quite frequently in patients who were getting radiated before. In post-radiation patients, it's sometimes it could be an issue. In your case, you might see colon cancer patients or rectal cancer patients got radiated before, then you might have insufficient cells. And when you have insufficient cells, then you don't have enough cells to test for HPV DNA. So your HPV DNA is going to come back negative. So don't take it for the face value. I mean, your HPV is come back negative, not because it's really negative, it's because you don't have enough cell to test for the DNA. Okay? So you have to keep in mind, it can be a false negative. So she come back 4 months later, and we did a cytology that was negative, and then now she can go back to the regular screening. Either you can do every 3 years PAP or Q5 years of co-test. All right? So at age 55, no, that's a separate patient. So she moved on with the screening. All right. Now, for the last patient, okay, 55 years old woman, she received annual pap smear screening to date, has been compliant. Her last cytology was last year, that was negative. Okay, and but she never had an HPV done. So what do? She just had a normal pap last year, right? So if you go by cytology alone, that's Q3 years. So you can do recommended cytology or move up the co-testing in 2 years. Okay, so she come back, she fall into the schedule now. Come back age 57, did a co-test cytology with atypical glandular cell, but it's not otherwise specified. HPV is negative. So how do we deal with this? If it's atypical glandular cells, okay, there are differences. There are atypical glandular cells not otherwise specified, okay, that's kind of okay. It's atypical glandular cells of favor neoplasia, that's treated the same as adenocarcinoma in situ. I will show you later, okay? So anytime there's a favor high grade or favor neoplasia, you have to take it seriously, even though it's agas or atypical glandular cell. If you see atypical endometrial cell, okay, then you need to do endometrial endocervical sampling. And there's no endometrial pathology, then you do colposcopy. So, or anything else, you have to do colposcopy and endometrial sampling. So when I was reading this, I was like, what the heck, I'll just do colposcopy on them. So for all these patients, the simplest way for me to do, I do all colpo and do ECC and EMC, regardless of what you are, because regardless of whichever you are, you need a colpo. I'm not gonna bring the patient back, wait until the biopsy result and bring the patient back for colpo. I mean, that's kind of silly, right? So I do colpo, endometrial biopsy, and ECC for agas, for atypical glandular cells. Now, so she got an adequate colposcopy. We didn't see anything. Biopsy negative, ECC negative, endometrial carotid negative, okay? So then the subsequent management, so if the initial is this, okay, is atypical glandular, not otherwise specified. Everything is negative, then you do co-test 1 year, 2 year, and then co-test 3 years, and then so you see fall back to the same triage pattern. Anything abnormal, colposcopy, and repeat the biopsy issues. Now, however, this is what I'm pointing out. Well, I want to point out. If you have atypical glandular cell favor neoplasia or adenocarcinoma in situ, these people need a cone. Okay, these people need a cone. So she come back for co-testing, age 58, both negative, and then come back again in 59. Remember, a year later, both negative. Then we say, okay, come back 3 years. 3 years, come back negative. So what do? She's getting close to 65, right? So when to start for screening? As I already briefly mentioned before, I'm not going to repeat it. Age 65 with evidence of adequate prior screening and no history. Okay, so this is the same thing. I'm not going to repeat it. You have to fulfill every criteria of this. Okay. Now, so she's never been diagnosed with CIN2 and had an agas, but it's not otherwise specified. HPV negative, colpo everything negative, HPV negative. So we do one more co-testing, and then she fulfilled the requirement, and then she exit. Okay. So that's the 4 cases very briefly. Pretty much cover almost all the algorithm. So where is this resource we can get? Now you can find these guidelines, ASCCP okay, and there are links to the PDF, and also you can download the algorithm. I actually download this algorithm and put in every computer in our GYN clinic. So all you have to do is find the icon, click it, the algorithm will pop up, and just fit the patient into that. Or if you really, or you can go to, it's a practice bulletin, or Green Journal, it's all been published. Or you really got $10 to spend and you're tech savvy, there's an app. Okay, so, I'm sorry, what is this? Can you close this? Where's that guy? Oh, not that one, this one. Okay, now, so if you really use your cell phone a lot and you got signal in your office, unlike here, then you can actually download an app. You pop in you can put in your patient information, age, HPV status, pregnant or not, initial result, and then they will show you the guideline. Okay, it's fairly easy to use, but costs $10. Yeah, go ahead.
Just a question to go back to the last piece. I was just wondering, when you said that even for glandular cells and favored neoplasia, because she didn't have CIN2 or greater, if she had favored neoplasia, would you still treat her?
I'm sorry, if you...
So she had AGC, favored neoplasia, not NOS.
Mm-hmm.
But she's coming to the time of age 65. Would we still treat her potentially like AI?
Oh, no, because that's why I very specifically said it's not otherwise specified. The AGC favor neoplasia is a different animal. It should be, that's why I say it should be treated as AIS, adenocarcinoma in situ. She doesn't fit this. No, she doesn't exit. Okay, so she does not exit. She has a what? Okay, she had hysterectomy before.
But the following is on the one we provided us at the history and did a pap test, a vaginal testing, and he come back was HPV positive, 60, 80. How to manage this patient?
Well, if you have HPV 16 and 18, it's it's, huh?
She had to do abdominal dissection.
Right, but the thing is, yes, the patient had hysterectomy, but then you are positive 16 and 18. There is a risk, still a risk for vaginal carcinoma, vaginal cancer. Those are the patients I would not, even though it's slightly deviate from the guideline, those patients I don't exit. If I have any doubt, I screen you. And I'll show you some paper that will kind of understand where I'm coming from. But I don't, if I have any doubt, I don't exit. They continue to screen, all right? So anyway, I'm not trying to sell this app, but it does cost $10, but sometimes can come in handy. Now, the two things I really want to point out is the recent development. Now, this exit screening at age 65 actually does create a little bit of issues that you have to understand. I want you to understand this, and it's, again, these are just guidelines, and it doesn't tell you what you have to do. As a doctor, you will have to use the best of your judgment. Now, I'm going to talk about this and also about the primary screening using the HPV testing. Okay, very quick. This is actually after the guideline came out back in 2012. Then this is May 2014, and the American Cancer Society's official journal, Cancer, actually published this data. It really asks the question, should you exit the patient at age 65? Because the statistics of calculating the incidence of cervical cancer, they actually included all women. They included all women in the United States. But actually, really, it should only include women who actually have a cervix. So, about 20% of all women will have had a hysterectomy in their lifetime. So, if you recalculate well, before you correct for the hysterectomy, for the population statistics, is about 11.7 cases per 100,000 women. But then if you recalculate the national rate, it's actually higher. It's 18.6 case per 100,000 women. And so actually the actual incidence is higher than what we anticipated for cervical cancer. And the most drastic change actually happened in age 65 to 69, which if they recommended exit at age 65, we would totally missed it. They recalculated the rate. It's about 27.4 cases per 100,000. So why we want to stop the screening the woman at the age where they're actually start peaking the incidence. If this is actually the data they actually reviewed. This is from SEER database from 2000-2009. They look at for all women. They looked at the incidence of cervical cancer, and they see it actually the uncorrected was this line. And then when they corrected, actually it was even peak. I mean, we'll see where they peak. I'm sorry, the slide is kind of blurry, but it peaks at 65 to 69. This is 65 to 69. And even after that, from 65 and above, the incidence is still relatively higher, even higher than the years that we were trying to screen the patients. So this is for the whole population. So if we break it down to among Caucasians versus black patients, same thing. I mean, for both, and even worse for African American patients. I mean, this is age 65 to 69. It peak and then start going higher. And then for Caucasians, it slightly drop a little bit, but still peak at 65 to 69. So that, this article actually created a lot of issue about whether we should stop or not. And I think for most of my colleagues, actually most G1 oncologists I spoke to, I mean, if this, because in patients who are actually not cancer patients, just they're general GYN patients, I think most of them actually continue to screen. I'm not gonna, this is not my official statement, but I screen them. I don't stop at 65. Even though they meet the criteria, theoretically they can. You have to use your judgment, who's low risk, who really can benefit from exiting the screening. Now, one thing real quick, again, Roche actually got this developed this COPAS, is primary high-risk HPV testing. What they do is they actually one testing total of 12, okay? They have 12 pooled high risk, and there's 16, 18, they test all these. Their strategy initially, they were advertising, they were trying to do this, and then if you're negative, you can continue to follow. Now, if you're 16, 18, specifically, you need a COPO. So if you're anything else, then they do a reflex cytology. They go back and do a PAP. The PAP is abnormal, you get a COPO. If PAP is normal, then you can follow. Okay, that means you basically, your cells has a viral DNA, but it really did not trigger any dysplastic change. But it raises the question, then should women be screened more frequently or less frequently? How frequent do you test? And how should the woman between age 25 to 29? Because in the guidelines, we're not recommending doing HPV testing, before age 29. So should we do it, or again, FDA approved it in April 2014 to use it as a primary, and the approval was for women start at age 25 now, and which is slightly conflict with the current guidelines. And will this lead to increase in colposcopy and cervical biopsy comparing to, because this whole screening algorithm change is trying to decrease the number of colposcopy and the biopsy. So then the ASCCP actually put out an interim clinical guideline back in 2015, and there's nothing follow afterward. So this is as the best as we can get. So the question then is it as safe, as effective as a cytology-based screening? Well, the study showed a negative HPV, high-risk HPV testing provides a greater assurance of the CIN3 than a negative cytology result. Okay, this is based on the literature. Now, can this be considered as an alternative to the current methods? Of course, it says can, otherwise FDA will not approve it, okay? But it's not endorsed by any of the major societies, okay? We make it very clear, it's not endorsed by any major society. It can be used. Now, how should one manage positive HPV? So it's the same algorithm as I point out. It's 16, 18, get Colpo. Negative, nothing's done. The other types, you could do a reflex cytology to screen. So what is the optimal interval? Every 3 years. That's a recommendation, okay? That committee's recommendation. And what age? 25 to start, right? So, but again, it's not endorsed by any society, okay? That's for your consideration. When you come across, don't get confused. Most GYN oncology, I'm including myself, I stick to the ASCCP guidelines, okay?
But it
90% were caused by the.
10% are not caused by the
No, well, no. 90% caused by the 16 and 18.
70%.
Yeah. So, okay, but anyway, this is a brief conclusion that I'm not going to repeat some of these, but basically, that's the, again, the endpoint is CIN3. Okay, so that's where we're going to stop, all right? Okay, thank you. I'll be staying around, so if there's any question, can feel free to grab it.